Okay, hi everybody. I think we'll go ahead and get started. We're right at 12 o'clock. Just want to thank everybody for joining us today. I am Amy Etzel, the Implementation Manager with the BREE Collaborative. Before we begin, just a few sort of housekeeping announcements. NCLAC will accept attendance at this webinar as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email later this week with a link to the survey, along with these presentation slides, resources, and a recording of the event. Please remember that if you want a certificate for a credit hour, you must provide either your license number or an equivalent ID number and complete the survey by next Friday, June 5th. If you have questions about this, please contact NCLAC directly. You are all currently on mute and you will be throughout this webinar until after our presentations. Today's speakers would love your participation in a Q&A discussion at the end. If you have comments or questions, please type them into your chat box or the question and answer box, and I'll use them to facilitate our session at the end. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. Okay, that ends our housekeeping portion of today. Now for a quick background on the BREE Collaborative itself. I do apologize, some of you have attended our webinars before and seen this content before. I will try to be brief, but not too brief for those of you who are joining us for the first time. So background on the BREE Collaborative. We are a public-private group in Washington State formed by our state legislature in 2011. Our goal is to improve healthcare quality, outcomes, and affordability throughout Washington State. Our collaborative members are made up of healthcare leaders from around the state, and we represent healthcare plans, healthcare purchasers, both private and public, including our state Medicaid agency and private purchasers, as well as representatives from various delivery systems across the state and other quality improvement organizations. So every year we select 4 to 5 healthcare topics or services that have a variation in delivery or outcomes that are used inappropriately or too often, and that maybe are not used enough, or that have a patient safety issue or an equity issue that our community cannot address alone or in any other way. So our recommendations are formed by clinical committees and work groups made up of community members with expertise in that selected topic. This collection of volunteers meets for about 9 to 12 months. And in the work groups, we review published literature, guidelines from specialty societies, work with other quality improvement organizations, national entities, and then programs and policies within our own delivery systems. So, as you can see, we've worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and we've also developed best practices for topics such as low back pain and end-of-life care. Our opioid use disorder treatment report and recommendation was adopted in November of 2017 by our community. And each of our guidelines, we usually frame them around specific focus areas. So our OUD report identified 3 focus areas to frame our recommendations around. These include access to evidence-based treatment, meaning medication-assisted treatment, or MAT, referral information for when MAT is not available on site, or for those patients who are not able to stabilize in an office setting, and then integrated behavioral and physical health to support that whole person care, essentially meaning making sure that there's a behavioral health component offered up to every patient with any MAT services. So, as part of the BREE's implementation efforts, I've been developing some starting ground implementation resources. These will be emailed out with our slides later today or later this week. The first here on the screen is an implementation checklist for clinic staff, outlining these 3 focus areas and then some action items that clinics can take toward implementation of our recommendation. Obviously, our clinical partners have far better depth of knowledge on this topic, and I'll let them get into the details of how this work is implemented on the ground later on in the webinar. But I do want to discuss briefly here and highlight a few of these actionable items. I also want to point out that this checklist here on the screen is aimed at primary care settings. There are some slightly different action steps that ED and treatment facilities would take, and I'll be developing resources, those specific settings in the coming months. We also here at the BREE fully recognize that not all of these steps are easily taken and that it will take a lot of time to fully implement. You all face such a wide variety of limitations within your clinics and our overall healthcare system around staff and budgets and reimbursements and etc. What we've laid out here is meant to be a pathway to full implementation, and in our mind, any progress down that path really is truly success for your patients. So the first focus area of our OUD treatment recommendation is about access to evidence-based treatment, that medication-assisted treatment, or MAT, such as buprenorphine, I can never say that word right, methadone, and naltrexone. I don't think that this is news anymore for most of you, so I'm not going to spend any time going over the details of these medications. Our full guidelines do go into more details, so feel free to read them in full. The back of this checklist that I'll email out later has links to the full guideline as well as some other resources available around this topic. What I do want to highlight and go into more detail on is really emphasizing that the work group focused in on a no wrong door approach to MAT, really taking the time to discuss all options and the associated risks of each medication with your patient so that they receive the care they need at the time they need and on their own terms. Next, we do really recommend training all staff on the stigma associated with OUD and the treatments to ensure that all staff really, truly, fully understand and see opioid use disorder as a chronic relapsing brain disease. Subtle word choices can truly affect the overall patient experience over the course of their treatment, and being very careful about the words chosen, even down to the detail of specific words to use when writing chart notes, can have a big impact. So take that time to educate yourself and your teams about stigmatizing language in relation to OUD. We also recommend trying to offer MAT services on site if possible, although we do recognize this is one of those areas where time, budgets, reimbursements, limitations, and maybe staff or community buy-in can be a hindrance toward this goal. Again, that's okay. Any movement toward these implementation steps of waiving some of your providers and writing those naloxone prescriptions is great. Also, part of this first focus area is having clear prescribing guidelines for your organization and provider teams to follow so that you're all relatively on the same page as much as possible. And then we finally remind providers to always use the Washington Prescription Monitoring Program when possible, or whatever relevant resource within your area if you're out of state when writing new prescriptions. The second focus area is about referral to treatment when MAT is not available on site and/or for those patients who are not stabilizing in an office setting. The best step you can take around this focused area is to really have a thorough and easily accessible inventory of the regional options regarding prescribers, behavioral health organizations that can offer up that behavioral health component, and then local opioid treatment facilities. Take the time to build an easily accessible resource for providers and care coordinators to use, and then familiarize yourself with the local options. Also make sure this is reviewed and updated fairly regularly, as we often know funding and perhaps a global pandemic can affect these options. If you live in an area that don't have a lot of resources, this can feel like an impossible task. So try to get creative, especially in the ever-changing world we live in with this emerging access of telehealth and telemedicine. If anyone has any questions on the resources that are out there, please feel free to reach out to me after this webinar. When you have that asset map and inventory in place, try to build in time for your staff to build up your relationships with these organizations and providers to ensure that smooth referral and transition and coordinated care as much as possible. I do know that this is another hard area. We talk all the time about how hard bidirectional care is, and I'm not here to argue around that at all. It's extremely difficult sometimes, and do keep trying to build up those relationships however possible and however incrementally really can help that extra level of specialty care for your patients to thrive. Another huge piece of this second focus area is having really clearly defined referral processes in place that all staff are extremely familiar with to ensure that nothing falls through the cracks and that the referral is completed. Having that supported component makes such a big difference. We really encourage a facilitated and supported referral. That support piece to the client is so important. Having that designated staff, if your budget allows, to help a patient navigate any potential barriers such as cost of transportation can really go a long way with patients and encouraging them to keep that referral and take treatment once engaged. And then our third focus area is about integrated care between behavioral and physical health. This is obviously such an important topic, this relationship between behavioral and physical health, even outside of the OUD space, and especially valuable when behavioral health is offered up with MAT. We really want to emphasize the importance of that whole person care approach. Again, I'm sure not a surprise to anyone here. growing studies and articles around the past trauma and ACEs scores and co-occurring behavioral needs among people with opioid use disorder, and how important that behavioral health component can be in improved retention rates and overall treatment success. To help this whole person approach become second nature for your provider and staff through an OUD lens, we really recommend training for staff on the impact that OUD has on a person's overall health, and also really digging into helping staff understand what an integrated care framework is and building that foundational knowledge base of the importance of integrating behavioral health into primary care. Again, there's a lot of resources out there on this, including, there's no bias here, the Behavioral Health Integration Recommendation Report that we put out in 2018. I'd be happy to help talk about these with anyone after the webinar and/or help gather resources for people that would like to educate their staff further. I have also identified some basic core process measures for clinics to focus in on, particularly for clinics that are in the beginning stages of prioritizing OUD treatment within their practice. Another aspect of my implementation work is to do some targeted practice transformation around behavioral health integration into primary care. So these are some process measures that clinics who have prioritized wanting to support their patients with an opioid use disorder, these are some process measures they can start with to move toward implementation of our recommendations. Okay, that is all I have. I'm going to turn it over to our experts now. We're going to start with Dr. Malcolm Butler, who will be speaking about MOUD services in a rural community health setting. Dr. Butler is a board-certified family physician and has been the medical director at Columbia Valley Community Health since 1995. He's lectured frequently on topics ranging from provider compensation to managing of difficult patients to chronic pain and opioid use. In 2005, he was named Washington State Family Physician of the Year, and in 2012, he received national recognition for leadership in opioid reduction efforts. And he was recently appointed health officer for Chelan and Douglas counties. So he's extremely busy, and we are extremely lucky to have him here with us today. Let's see, trying to unmute you, Dr. Butler. Give me one moment.
I'll do that.
Okay, sounds like you're good.
Good. Well, good afternoon, everybody. I actually looked at the list of attendees, and I can see many familiar names out there, and to many of you, I'm preaching to the choir, so I apologize for that, but thanks for tuning in. Yeah, as Amy pointed out, on April 20th, I was appointed as the health officer for both Chelan and Douglas counties, and word of advice, if there's a really bad time to become a county health officer, it was April 20th of this year. Anyway, so I grew up in and around the Seattle area. I went back east for my undergrad and then came back to the University of Washington to do my medical school, Ventura County for my residency in family medicine, and then came to Wenatchee in 1993. Practiced full spectrum family medicine for 25 years, have delivered over 1,000 babies at our local hospital. And then life happens and we got pushed out of the hospital. And so for the past 3 years, I've been doing outpatient only practice. My entire career, I've worked at an FQHC, Federally Qualified Health Center here in Wenatchee. We're largely caring for a migrant Hispanic farm working population and a low literacy, low income Anglo population. Just in general, I think at baseline, our population has fairly poor coping skills, an enormous amount of what I call horrible life syndrome, a lot of adverse childhood experiences, a lot of PTSD, a lot of behavioral disease, personality disorders, and so on. And I mention all of that because I think if I can do this, if we can do this in this setting, which arguably is a difficult setting in which to do it, it should be possible for almost any primary care setting to do this. When I was speaking with Amy about sort of, what would be helpful for me to talk about today, we decided to sort of talk about how this is possible and how it has been possible for us. And that's really what I want to focus on. I'm also going to lament briefly the fact that just, 6 years ago, this was MAT, and now it's MOUD, and come on, I can't keep up. So I'll go back and forth between MAT and MOUD, and forgive me for that. At our center right now, about 90% of our primary care providers are prescribing buprenorphine. We have a pediatrician and a midwife who are prescribing. And right now, typically over the last year, we average about 200 patients under treatment at any given time, to give you sort of a feeling of the scope of what we're doing here. So I want to make a case that beginning to treat opioid use disorder as a primary care provider is arguably one of the most impactful things you will do in your career. And I'm going to sort of highlight that a little bit more at the end, but I think that's the takeaway. When we think about, what do we want to be remembered for outside of surviving COVID-19, I think, if you pick up this challenge and run with it, you will be very pleased, and it will be one of the things you're most proud of. Unlike most of the things that I do in primary care, treating opioid use disorder, in the vast majority of cases, I see results, and the results I see are fairly profound. I cannot think of any other activity outside of maybe delivering babies or, setting fractures that has been as impactful as quickly. Almost all of these patients are grateful. They are attentive, they are engaged, appreciative. Almost none of them miss visits. In fact, when they do miss visits, almost always that means something has gone wrong. And those who really don't fit that profile weed themselves out pretty quickly. And at the end of the day, this is easy work, and it is fun work. And that is so counterintuitive to how I imagined it would be before I got started. Medical director in Snohomish County, Tom Tosher, was an early adopter of this. And Tom said, come on, you guys, you all got to do this. It's totally fun. And none of us believed him until we started. And then we realized he was right. It is fun and it is easy. Caring for a diabetic patient is much more difficult than caring for an opioid addicted patient today. That wasn't true in the past. So I also want to make the argument that this is the sort of a perfect primary care activity. And like all primary care activities, there are going to be cases which are too complex for us to manage. We are all comfortable and used to referring to higher levels of care when necessary. And certainly there are opioid use disorder cases that are just too complex for a primary care provider. And as Amy was mentioning earlier, knowing to whom you can refer will make this possible. I think until you have established those relationships and solidified them, I had actually not thought before about setting aside time to actively go out and build those relationships. I think that's an interesting point that Amy brought up. But when you know to whom you can refer, and when you are comfortable that you can get your patients there, you'll be much more willing to take on the challenge. And I think that's the same with asthma and severe headache and severe pain, any of those things. If we know that there's somebody there to take our complex cases, I think we're more willing to put our toe in the water and then venture in up to our waists anyway. And I want, if you think about Ed Wagner's chronic care model, which was introduced probably 20, 25 years ago now, what he talked about was having an informed and activated patient and a prepared, proactive practice team. And I think that's what I would like to talk about some today. These patients do not come in prepared for much other than getting the monkey off their back and getting clean. And it took me a while to realize that these are not all emergencies. For a long time, it felt like, gosh, somebody comes in and they're sober and we got to jump on this right away. And in reality, they have been living their life. They've been using opioids. They've got that strategy sorted out. And we can take the time we need to onboard them correctly, to get to know them, to tell them about our program. And if we need to say, you know what, your disease is worse than I can handle. It's too complex for me and I need to refer you on. So I guess I'm sharing that early in my practice, I really felt this emergent need to get something taken care of, even if it felt risky to me. And I've grown out of that. I think we can take the time to do this in a thoughtful way. So and I say that because the patient may be too activated. They may come in sort of screaming and yelling and demanding that you must treat them now. And in fact, that's not true. They'll do fine. And in fact, they may do better when they know that you've taken the time to take good care of them. Ed Wagner also talked about self-management support. And so I think it is important, as Amy pointed out, that we do have standards of care within our facility so that everybody knows what we're doing. I have those, I've had them, I'm happy to share them if anybody's interested in them. I think it's super important to have an RN or a behaviorist who's on your team with you, helping you manage the details, and then sort of taking care of the behavioral issues when you may not be present to cope with those. And then finally, that the clinic design supports the activity. And so again, standards around MOUD, MAT, about how you report cases. There are these issues, as you probably know, that you can't have more than 30 cases until you've upgraded, and then you can't have more than 100. There's a whole bunch of testing and other things that we're supposed to be doing all the time. I will share with you that during the first 6 months of my prescribing, I got a visit from the FDA, 2 very young, handsome-looking folks who came to ask if I knew exactly what I was doing and to ask me specifically what is the current street value of buprenorphine, and I had no idea. I was sort of a little frustrated internally when they visited with me because I had been prescribing massive doses of oxycodone and methadone for the 20 years prior, and they'd never bothered to swing by and tell me I was being an idiot. But as soon as I started trying to help people, they swung by to make sure I was doing it correctly. Anyway, that does happen. They do like to see that you're thoughtful and that you've got, you know what the standards are and that you're practicing within those standards. So, as I've thought through this, why do we feel this resistance to picking up this, this task, this challenge? Why aren't all primary care practices galloping towards it? And I'll tell you my personal experience, and that was my life experience with addiction has been that it is hopeless, that these patients are manipulative and demanding and hard to get along with. And why on earth would I invite that into my practice when I already feel completely overwhelmed with what I'm doing? I don't need any more chaos or craziness. Thank you very much. And I bring that up because I imagine other people on the call have felt that way too. And what I need to share with you is that is what an addict looks like when they are in withdrawal or when they are seeking. When they are being treated with buprenorphine, that is not what they look like. The chaos goes away, the manipulation goes away, the anger goes away, and they become these incredibly grateful people. And that really helped me develop, I think, the empathy that's required. Amy was talking about destigmatizing. When you realize that these are absolutely average, normal people who have a badly wired brain, who exposed themselves to opioids and got in trouble, and that how profoundly grateful they are when you help them with that disease. This is a brain disease. This is a chemical thing. And to see how they struggle with the loss of control, I think does help one become empathetic, and it does help one not use the stigmatizing words that I grew up with and was trained with, certainly. So, addiction to me always appeared to be sort of a one-way tornado towards a bad outcome. And when I trained at Harborview and when I trained at the county hospital in Southern California, and when I came into practice, I mean, it was cirrhosis, cirrhosis, cirrhosis. It was methamphetamine, methamphetamine, and nobody got better. People rotted out their heart valves and they basically all died a very bad death. And then as I matured in my practice, I sort of moved up in the medical staff in our local hospital, grew into a leadership position in the medical staff, got on to the credentials committee. And what I suddenly realized was that we had dozens of addicted physicians on the medical staff. And I had absolutely no idea. And that just kind of turned my world upside down, because as far as I could tell, an alcoholic got worse and worse and worse until their liver went south, and then they drowned vomiting their own blood. And that wasn't what was happening with physicians. And of course, you know, physicians typically come from privileged backgrounds and are high literacy and have pretty exquisite coping skills, and have a heck of a lot to lose. And with that combination, they do okay. It takes support, you know, they typically have good social support, and the physician health program helps monitor them, but they all did pretty well. And that really shook me up a little bit. And then one of my partners started managing opioid use disorder with buprenorphine, and his patients seemed to do well. And then I started doing it. And what I realized is, again, I mean, we need to imagine what it was like treating diabetes before there was insulin. You can imagine back whenever that was, in the 20s or the 30s, and people would come in and you'd tell them that you've got diabetes and you need to make very careful and good choices around your diet. And even if you do that, you're probably going to die. And there was nothing to do until suddenly insulin comes along, and now you can treat it and people can lead fairly normal lives. And that's been my experience with opioid use disorder and addiction in general. Although we have nothing close to buprenorphine for the other addictions. But it's a brain disease, and you replace the required chemical and they can lead fairly normal lives. Now, as Amy pointed out, and as the Bree Collaborative points out, this is a chronic relapsing disease. And I tell everybody when I onboard them, this is a chronic relapsing disease. If you relapse, that's fine. Don't lie to me, don't cheat, don't manipulate, don't steal. But if you relapse, you come in and say, Dr. Butler, I relapsed. And we'll just start again. It's not a big deal. It's what we expect. And again, I couldn't have said that previously. When I used to have an alcoholic relapse or somebody smoking tobacco relapse, I got really frustrated about all the time and energy I had put into that, and how wonderful I was for having helped them finally get clean. And then they start smoking again. And, you know, again, that's the negative reinforcement for even trying to help people quit smoking. But in opioid use disorder, they get better. You put them back on their Suboxone, back on their buprenorphine, and again, they pick back up where they left off. So let me see where I am on my notes here. One the other thing, yeah, that was easy, and I picked up now. Again, I used to get frustrated at people who relapsed and would say things, and now I can just say, you know what, these people are just acting like an addict. They come in and they refuse to give you a urine, they miss their appointment, and it's pretty easy, you know, they relapse. You know they did, either that or they're in jail, and that's okay. That doesn't mean they're a bad person or that they're trying to take advantage of you. It means they've got a chronic relapsing disease. And, you know, we wouldn't exclude somebody from our practice because they had an A1C of 12. And in the same way, we wouldn't exclude an opioid addict who has relapsed. The other thing I would say in managing opioid use disorder, it's given me a much better appreciation for other addictions, for tobacco addiction, for alcohol addiction, and for food addiction, and for pornography addiction, and for gambling addiction. And about 5 years ago, I challenged my team that really addiction is the last great frontier of primary care. I mean, if we can sort out food addiction, then, I mean, we've got obesity and low back pain and diabetes and all the other things that go along with obesity more or less licked. And I think it really does increase your capacity to understand how a morbidly obese diabetic patient just cannot say no to food, because you've seen that crazy loss of control in your opioid patients. Behavioral medicine is a huge facilitator of these activities. We've had integrated behaviorists on our team since 2004, so 16 years now. They're just great to have as your wingman when somebody's doing something and you just can't quite understand it. You can lean on them. They'll do an initial evaluation to make sure that a patient is a good candidate. And then we because you remember early on I said you need someone to refer them to if you're going to do this well, and we did not have a great place in town to refer people to consistently. We built that ourselves. So in the last 3 or 4 years, we've actually brought a treatment program in-house and under our auspices, and it's run by our behaviorists. So anyway, the behaviorists are a great addition, and like I said, wingman, I think you can do it without that, but it would sure be more fun and easier if you had that. So finally, what I want to say is life expectancy in this country peaked in 2014. And since 2014, we have continued to do better with cancer and with infectious disease and with heart disease, and yet life expectancy has continued to drop. And I think everybody on this webinar knows that is related to opioid use disorder and to accidental opioid overdoses. Leading cause of death between the ages of 35 and 50 in Washington state is accidental opioid overdose. I can tell you that in my clinic, we have not had an accidental opioid overdose since 2010. And that's because we started early worrying a lot about opioids. What I can tell you is now we have one more tool to help in our chronic pain patients when we recognize they have opioid use disorder. And again, knock on wood, as far as I'm aware, we have not had any of our Suboxone patients have an accidental opioid overdose while they are using Suboxone. We have had people relapse or go to jail and come out and use too much. So it's a dramatic intervention that you can make. And I think if all of us as primary care providers take on treating opioid use disorder and addiction in general, we're going to turn that curve back around and get it going in the right direction. So one of the most impactful things you can do in your practice, fun, not that hard, and I hope all of you will take me up on the challenge of adding this to your practice. Thank you.
Thank you so much, Dr. Butler. Such great work you all are doing. Those are some impressive statistics you showed at the end. Next up, we're going to move on to our second presenter, Addie Adwell. Addie is a registered nurse and opioid use disorder nurse care manager working at the Harborview Medical Center in the Adult Medicine Clinic. She also serves as the Western Washington OUD Care Manager Trainer for the University of Washington Ames Center. So I'm trying to unmute you. Give me one moment. All right, I think you're all set now, Addie.
Okay, great. I have two objectives to achieve today. I'm going to explain the nurse care manager model for treating opioid use disorder, and I think thank you, Dr. Butler, for that really great pitch to do this in primary care. I'm going to describe a staffing model that you can use to really leverage prescriber ability to the full maximum extent of the waiver. And I don't want you to think, how can I take this just out of the box and implement in my setting, but just what pieces feel like, oh, I could see that working in my setting, because we're all in different types of settings. And then I'm going to hopefully spend some time discussing how we've adapted, how we're delivering care for OUD during the COVID-19 pandemic. Next slide, please. So some people haven't treated opioid use disorder in primary care, and they've identified that there's real barriers to delivering this medication for opioid use disorder, or MOUD. These are two articles where physicians were interviewed about why they have not taken up prescribing buprenorphine in primary care. And the first article interviewed 92 physicians, found that only 28% of them were with a waiver were prescribing. So people had gotten the waiver, they'd done the training, but they weren't using it. And they really felt like they didn't really have the psychosocial support needed for their patients in order to do this effectively. In a second article, there were 156 waivered physicians who were interviewed, and they identified they didn't have sufficient nursing support, they didn't feel like they had the office support, and they didn't have the institutional support to deliver this care. So what could we do about it? The next slide, please. Massachusetts model of collaborative care was developed at Boston Medical Center in 2013 to address those specific challenges that physicians had identified. And I'm saying physicians because at the time, only physicians were allowed to be waivered. I think since that time, nurse practitioners and physician's assistants are also able to get a waiver to prescribe buprenorphine and prescribe. but it uses a multidisciplinary team with a nurse care manager in kind of a clinical linchpin role, along with a program coordinator to provide office-based opioid treatment with buprenorphine. We also provide Vivitrol, but that particular medication doesn't have so many of the regulatory requirements attached to it. For example, it doesn't need a waiver. The DEA doesn't show up on your door and ask you to prove that you know what you're doing. We implemented this model at Harborview in 2016. And since then, we have implemented it in every single primary care setting in our campus, in our behavioral health setting, in our inpatient setting, and in our ER. Each little setting has required a tweak to the model, so I'm going to describe it in broad strokes, and then if you have really specific questions, I'm happy to, my contact information is available at the end. Next slide, please. So the benefits of the model are that the prescribing providers get that support structure that they have told us they did not have in order to prescribe buprenorphine in primary care and to prescribe it at high volume, really maximizing the capacity of that waiver, whether it's 30, 100, or 250. Patients, they may benefit from a setting that provides more anonymity and convenience. I don't want to go to the OTP because I feel like then the whole community knows my business. I want to come to my primary care office where I also go to get my flu shot and where I go to get my hepatitis C treated. That feels a little more convenient for me. It facilitates treatment of comorbid conditions and allows us to deliver preventative health care to a population of people who need it but aren't seeking it out necessarily. And it's possible to engage non-treatment seeking patients who are screened in primary care. You might have patients on your panel who have been on chronically prescribed opioids for a really long time, and they have kind of tipped over time into developing an opioid use disorder. You have a possibility to transition them into opioid use disorder treatment without changing setting, without changing provider, and really maximizing safety for them. Next slide, please. So this is the sort of broad strokes of the model. We start with an assessment. We bring people in. They talk to the program manager who describes what the program treats. This is really important. People sometimes want it to treat methamphetamine, the medicine. It doesn't work for methamphetamine. They meet with the nurse care manager to do an assessment and to go over the program agreements, what patients can expect from us and what we'll expect from them. And then the provider meets with them for chart review, a physical exam, to diagnose and to make the treatment decision. We describe our approach as screen in, not screen out. So in our screening, we're really trying to learn what are the barriers, what can we do to help you navigate those barriers, how can we put together a package of services that's really going to serve you at the highest level. Then we want to get the patient on the medicine, so the prescribing provider writes the prescription and the nurse care manager teaches the patient about the medicine and makes a plan to start. We do the vast majority of our medication starts as home starts. I think there's a lot of, people think it's more complex than it is, I think, to get people started on this medicine. And then you're into the maintenance phase where you're helping the person stabilize on the medicine, stabilize the surrounding chaos of use disorder, figuring out, again, that package of services they need in order to maximize their treatment, and addressing lapses, addressing if treatment kind of goes in a different direction. And the patient is meeting with the provider periodically, both for maintenance of their opioid use disorder, but also for their ongoing primary care needs, with the goal of really increasing access to opioid use disorder treatment in a clinically and cost-effective way. Next slide, please. So this is sort of, again, what the intake includes: assessment with components of opioid use disorder, other substances, treatment history, chronic pain, mental health history, and social history. Not because we want to say, oh, you're homeless, you can't come to our program, but because we want to say, we noticed that you don't have a home. Can you and I talk about how you're going to keep your medication safe so you don't lose it, right? Really trying to address those barriers up front, address the pieces of a person's individual situation. learn the patient's goals for treatment. They may actually be different than the program's goals for treatment. That's okay. Just discover where the difference is and then move towards the middle. Our program's goals is abstinence from opioids. Ideally, we're all on the same page about that from the beginning, but patients may have really different goals for treatment, and you want to know what those are. Review the treatment agreement, medication teaching, planning for medication start. Look at that prescription monitoring program, and then build rapport and engagement. You want your patients to know that you care about who they are as a person, that you want them to come back no matter what happens, that you're really excited they're there, and you're so grateful for the opportunity to help them with this disorder. I can't stress enough how so many of our patients have had really traumatizing or negative interactions with the healthcare system, and you have such an important opportunity to change that narrative for this person. Next slide, please. Follow-up visits. We do our follow-up visits weekly until the person is stable. And I put that in quotes because stable can look like a lot of different things. It doesn't necessarily mean for every person that they've totally stopped using all substances. But until a person has some stability, we meet with them weekly and then less frequently after that. We're always assessing how the medication is working, talking about adherence to the medicine, craving, withdrawal, any thoughts that the patient might be having about tapering. We don't usually bring that up, but sometimes patients think, I'd like to try a little lower dose and see if I can manage on that. We always talk about substance use and address any lapses, and we use that as an opportunity to consider additional treatment supports like mutual support groups, behavioral health supports, vocational support, peer support. We do a urine drug screen and we look at that prescription monitoring. Next slide, please. We use a multidisciplinary team consult meeting twice a month to talk about interesting or challenging cases. I've listed some examples there that I'm not going to go through, but we found that our team really benefits from this to develop consistent practices across providers. It gives us an opportunity to share knowledge with each other and to understand that we always have clinical backup available. And it really helps us have attention to unintentional bias, given the vast different groups of people that come in with opioid use disorder, to make sure that we're applying our practices consistently. Next slide, please. So there are challenges to implementing this model, and these are the ones that I found initially. Hiring qualified staff. I think more and more the healthcare workforce is getting some training and exposure to working with people who have use disorder, but it can be still a little bit hard to find. When I look to hiring staff, what I look for is somebody who has a real desire to work with this population, who really feels strongly about treating use disorders and working with people who have use disorder. I can teach all the other stuff. And I think there are healthcare professionals who feel really strongly pulled towards this work. It's the best job I've ever had. I agree with Dr. Butler. It's very fun, it's very challenging, it's incredibly rewarding. Other challenges, you may need to rally the institutional support. You may hear from people in the clinic about they're worried about those people being in your waiting room, that kind of thing. They're already in your waiting room, first of all. And then second of all, once you get a few patients, people see that this is really a population of people that's pretty easy to treat in primary care. And then last, of course, is the financial sustainability, figuring out a mechanism to bill for those nurse care manager visits or care manager visits so that you can really maximize the model. So I went through the model very quickly, and I'm happy to take questions. My contact information is included, but I'm going to change gears and talk a little bit about how to maintain medication for opioid use disorder during the COVID-19 pandemic. And this is an interesting challenge for us because we are treating an epidemic, a public health epidemic, inside of a global pandemic. Wow, who thought we would have this opportunity in our lifetime? So just set some priorities in your mind, and these are the priorities that I set for myself, which is I'm going to maintain medication for opioid use disorder with decreased in-person contact, both for my current patients and for my new patients. I'm going to try as hard as possible to reduce harm, both from COVID-19 and from opioid use disorder. And I'm going to follow the recommendations from public health experts for both of these disorders. Next slide, please. The Washington State Health Care Authority has provided some guidance on how to do this work, and I just recommend you bookmark these links because they've been updated throughout the pandemic. And I'm going to highlight a few key points. Next slide, please. So one really crucial thing to know is that telemedicine appointments for an initial diagnosis of opioid use disorder and prescription of buprenorphine is possible during the COVID-19 pandemic, as long as that national emergency has been declared. This was previously only available in an opioid treatment setting, but you can do telemedicine for MOUD first visit right now. It has to be for a legitimate medical purpose. It has to be done using telemedicine, which is that audiovisual Realway 2-time interactive system, and you have to be interacting in accordance with the law. For billing help with this, I did include the Washington State Health Care Authority billing site. I think that there is some hope on the part of many practicing prescribers that this telemedicine option will continue in the future, and there may be some advocacy work in place to continue this. I think people have really liked having this as a possibility. Next slide, please. So I described our model. We made some changes to our workflow in order to help people comply with the state order of stay home, stay safe. And I understand that we're joined by people from all different regions. So you may live in a county that is under a different phase of this order, but we considered longer interval between follow-up appointments to decrease people's travel time. For some patients, we went to exclusively phone visits. We said, we don't want you to come in. We're gonna prescribe a longer prescription. We want you to pick it up. We want you to be able to stay home. We collected urine drug tests less frequently. We felt comfortable with that because in our program, we don't make clinical decisions based exclusively on urine drug tests or even on a single urine drug test. We prescribed longer prescriptions when it seemed appropriate, and that was a shared decision-making process with the patient. If the patient said, you know what, Addie, I can't have a 2-week prescription. It's just not gonna work out for me. I really need to have a shorter prescription. Great, let's do that. But for people to have decreased trips to the pharmacy, we did prescribe longer prescriptions, and we really weighed the relative risks before asking patients to come to the healthcare setting. I will say in April, we asked almost nobody to come here. We did mostly telemedicine, mostly phone, mostly long prescriptions so that people could just really stay at home. And we also made a plan for getting medication to patients who had to stay in isolation because they had respiratory symptoms. We established relationships with a couple delivery pharmacies. We created a protocol to get medication delivered using our staff here if people used our pharmacy financial assistance. So just some options to think about. The other thing that I consistently did with my patients was I thanked them for being mindful of public health and for being participatory citizens in that way. I don't think our patients are often experiencing gratitude for the way they're participating in society, but a lot of my patients really wanted to follow the recommendations by public health, and I think that was a really good indicator of progress in treatment. Next slide, please. So this pandemic has had a really big impact on patients with opioid use disorder. If you think about how patients with opioid use disorder may come to you with histories of trauma, they may come to you with history of significant loss, they may come with history of real distrust of the healthcare system, and now you layer on that they may have lost their usual recovery or mutual support groups, or maybe in a format that they can't access. They may have lost their job or been laid off. Because we shackle job with healthcare in this country, they may have lost their health coverage. They may be struggling with housing and food insecurity, and their appointments with providers that they rely on or typically see may be changed, canceled, shortened. So our patients are really bearing a huge load in this pandemic. So what should we do? Next slide. In order to support our patients. I think it's so important to maintain contact with patients throughout this. Check in with people, find out how they're doing. I have several patients that I talk to on the phone weekly, even though they aren't due for a prescription. We're just doing that in order to provide some level of routine and support for them. It's important to be aware of the resources for financial, housing, food assistance for our patients nationally and in local areas, or connect them with somebody who does know about those resources. Connecting people with alternative recovery support options like virtual support groups has been really helpful. And then I'm really anticipating that my patients, some of my patients, not all, but some are going to need more support when this acute phase is over. And I'm also anticipating some destabilization of their use disorder. And I'm really trying to normalize that for people. Last slide. Lastly, harm reduction, making sure people have that naloxone in their home, making sure somebody knows where it is. I worry a lot about my patients who live alone and who may still be using, so I've given out this Never Use Alone, which is a phone call that they can make to say, I'm gonna use right now, and the person will stay on the phone with them, and if they don't respond, they'll contact the local emergency authorities. So that's really helpful if you know people are still using. And then Yale put out a really nice fact sheet about harm reduction during COVID-19, substance use disorder, and reducing harm from potential respiratory virus that has also been helpful for harm reduction. And thank you so much for letting me talk with you today.
Thank you, Addie. That was a wealth of information. Thank you so much for fitting all that into 22 minutes. We do have 8 minutes left, and so I'd love to open it up to the audience. I'm gonna take the risk of trying to unmute us all and hope it doesn't instill chaos of noise. And then also people can feel free to enter questions into the chat box or the Q&A. I'm sorry, I have two screens going. I'm trying to figure out where I go to unmute everyone. So if you have a question, also feel free to enter it in via chat, because that might happen quicker than I can find unmute for everyone. I'm gonna unmute Dr. Butler though, just so if he has anything to add, you can go for that. I apologize for my inability to unmute everyone. I'm keeping an eye on the chat boxes though. Go ahead, Dr. Butler.
I do not have anything else to add. I agree with everything Addie said. She said it very nicely.
Excellent. While I'm trying to figure out my technical difficulties, I just had a question that came up while you guys were talking, and I'm just thinking about some of the communities that I've worked with that are very remote and that don't have, you know, a nurse care manager, and what suggestions or tips do you might have to implement some of the things that you've had success in treating your patients when you don't have as much support? Any suggestions there?
I think one of the problems that people have, and probably one of the problems that Addie saw when she saw a whole bunch of people have the waiver, but they aren't actually using the waiver, is just because you have the waiver doesn't mean you have capacity within your practice to take on any new patients. So if you're in a small rural community and your practice is already full, it sounds like it's probably time to hire a new provider to let that happen. I think, again, it feels there's like this activation energy to get into prescribing Suboxone, and it feels scary because you're already so busy. And again, this work, like I've said, is less than caring for a diabetic, in my experience. Now, you do see them more frequently, but typically they're the feel-good visits. A lot of these people have horrible lives, and they bring that in with them. But I think in our practice, we do have a nurse who coordinated our data for us, and we tried to get the nurses to sort of play a more active role, but it turned out that fell a little bit more naturally in our configuration to our behaviorists. So in a very rural setting, I think you probably can't take on 30 clients, but maybe you can take on 5, and then you can teach the rest of your team how to help you doing that. And once those 5 are stabilized, you take on 3 more. And once those are stabilized, you keep slowly building the practice.
Sure. Addie, do you have anything to add before I move on to the next question in the chat box?
No, I don't have anything to add. I think that's great.
Thank you. Thanks, both of you. Question is, if a person is homeless, how do you help keep medication safe?
I'm happy to answer. I think make a plan with the patient about how much medicine they can have with them. If you know of any shelters in your area that provide medication lockers, you can try to connect your patient with medication locker. If you have a patient who's persistently losing their medicine or getting it stolen, you might consider the long-acting formulation of this medicine called Sublocade. This is a really good intervention for people who don't want to remember to take a medicine every day or who have trouble for whatever reason holding on to it.
Thank you. Anything to add, Dr. Butler, before we move on?
No, I just say we've had some challenges with Sublocade, how you get it into your clinic and administer it to the patient, and the FDA has some the DEA has some inconsistencies around that. So, yeah.
Be careful there. Okay, thank you. What feedback would either of you have to the healthcare authority or our legislature? I'm assuming this is around the recent changes to telehealth that may or may not maintain, while the need for telehealth and telemedicine does maintain.
Well, I guess my comments would be that I think the physicians anyway who are running the HCA have a great deal of experience in this area. And are great advocates and have been great advocates. So the biggest issue, I think, is just the stigma that I myself carried before I got into this business, that, you know, these were people who were made bad choices and had to live with the consequences of their bad choices. And I think helping the legislators who turn over regularly, and unless they've got it in their own family, might not appreciate how much of a brain disease it is, in some way helping them with that message.
Sure. Anything to add, Eddie?
No, I agree with that. Yeah.
Okay. We have a question in the Q&A chat box. Given the substance epidemic coming from social isolation, can you speak to the rise of social prescribing and any key behavioral interventions that help insulate the vulnerable against slipping into usage? P.S. They love your empathetic attitudes and enthusiasm. So thank you for that.
I'm not on social prescribing. Do they mean street use?
Let's see if we can find Alex and unmute them. Or Alex, if you want to type in a follow-up to that question that you typed in. I'm having trouble with the unmuting. I apologize.
What I would say is, as Addie pointed out, I think this population is at incredibly high risk when they're being socially isolated. Such an enormous part of long-term recovery is being in a socially supportive environment. Obviously, we've all heard of NA, but just having your family around. I have, you know, my patients who do the best are so proud of the fact that their family talks to them again, that they have Christmas with their family again, and to have that taken away from them puts them at great risk.
Okay. Someone asks, do you support adding traditional SUD one-on-one counseling group treatment along with MAT, and do you see better results?
I am always supportive of people engaging in additional services if that is what the patient wants. I see the best uptake of it and the best results from it when it's the patient's idea. And, you know, sometimes we're guiding patients in that direction because what we've tried so far hasn't worked. I think it is important to, wherever you're referring people for the substance use disorder one-on-one counseling or intensive outpatient treatment, just to confirm what that agency's perspective is about medication for opioid use disorder, so that you're not setting your patient up to walk into a setting where they're going to be talked out of taking this medicine that we know is really crucial to stabilizing their brain disorder.
Sure.
Yeah, and I agree absolutely. I'd make the analogy to treating depression. We can treat depression just with an SSRI, but treating it with an SSRI and a behaviorist and a lot of exercise gives better results.
Sure. We had a follow-up to the social prescribing, and it comes from an attendee in Canada, which is exciting. Social prescribing is a new term in the medical community here in Canada, i.e. doctors prescribing social interventions and support. So I just wanted to read that out to you all. I do want to be cognizant of our time. We've just hit 1 o'clock. I did see in the chat box, someone asked what are some examples of language to avoid, and I will say that I will provide a link to non-stigmatizing language around OUD with the webinar and the webinar link of the recording. So I will send out a resource on that. I do want to just put in a quick plug for our next webinar on June 24th, which will be around the use of motivational interviewing in the SBIRT model. Our first 4 webinars have been somewhat of an overview of 4 of our behavioral health related guidelines, and moving forward, we will be moving into more nuanced topics related to behavioral health integration. And so starting in June, it will be on that topic. The links will be live in the webinar slides that I send out later this week, as well as a link to join our mailing list, which will give you all of the really exciting BREE-related news we have to offer, as well as future webinar announcements. We will be offering webinars monthly on the 4th Wednesday at noon. Topics after June will be announced as we go forward. I want to thank you both for joining us today, and thank you to our audience, and please feel free to reach out to any of us with follow-up questions. Thank you, everyone.